Hello, friends. Today we'll be going through the second week of development. So, the second week of development is the implantations phase, and it's considered the week of twos because everything it develops into two layers. So, implantation is done by day 9, and the blastocyst, that's what the fertilized egg is now, it implants into the endometrial stroma of the uterus. Here it goes. So remember, it's done fertilized ovum from the ovary, and then once it's the egg and sperm joins, that's conception, and then it's the zygote, and then during the first mitotic division, it forms the polar body, and then it's into the two-cell phase. This is still in the fallopian tube. The 16-cell phase is the morula, and then it becomes the blastocyst. And then it starts implanting. And the trophoblast, a layer of the blastocyst, will develop into the cytotrophoblast, which is the inner layer. It is mononucleated and they have distinct boundaries. So these are bound cells. And on the outer layer is the syncytiotrophoblast. It's multinucleated and they are unbound. So the cells, they lose their boundaries and kind of merge into one kind of general layer of tissue. The cells from the inner layer, the cytotrophoblast, will undergo mitosis and then they will migrate outwards into the syncytiotrophoblast. And then the syncytiotrophoblast, respectively, will cause the endometrial cells to undergo apoptosis as it pushes inward. So here is the syncytiotrophoblast. It migrates and then it pushes outward into the syncytiotrophoblast, and from there it pushes into the maternal endometrial tissue and then cause those to degrade as it implants further. So it forms the room for the cyto the blastocyst to implant. The lacunar stage is when the vacuoles, these little pockets, will fuse, and then those will make larger pockets called the lacuna in the trophoblast layer. And then the syncytioblast will cover the entire blastocyst except for where the little implantation site or the coagulation plug is. These layers secrete the human chorionic gonadotropin hormone, HCG, which enters the maternal blood via the lacuna. So it secretes it, goes into the lacuna, and then from there it interacts with maternal blood. The HCG will maintain the corpus luteum secretion of progesterone, which will, of course, maintain the endometrium so it doesn't signal the maternal hormones to start menses. The secretion will be prolonged until it is permanently replaced by the placenta. The cytotrophoblast will form the primary villi that will penetrate the syncytiotrophoblast, and that's how they migrate from here's the primary villus, and then it goes deeper into the second chorionic villus, and then it starts branching into the tertiary villus, and from there the cells migrate into the syncytiotrophoblast. The embryoblast will differentiate into two layers: the epiblast on the outside, which will house the chorionic cavity in the future, and then the hypoblast, which is the primitive endoderm. These two layers will form the bilaminar or the blastoderm or embryonic disc, and the primitive dorsal ventral axis is made. So right now we're kind of forming something that has a spine, and then the hypoblastic cells will make the prechordal plate, And the epiblast will eventually give rise to the amnioblast, which will give rise to the amniotic cavity. So here it goes, epiblast, hypoblast. Here's the blastocell. And here it is, starting to form the amniotic cavity. And then it differentiates and forms the primary yolk sac. Okay, so the amniotic cavity is filled with fluid. It's to protect and to cushion the developing fetus, along with some form of like nourishment. The layer of epiblast cells expands into the embryonic pole and differentiates into the thin membrane separating the amniotic cavity from the cytotrophoblast. And then the membrane is the lining of the amnioblast. So there's a bunch of those cells. And then in the 8th week, the amnion will enclose the entire embryo. So this is more like in the future. You can see like a very clear amniotic cavity, but here during the actual like 13th day of development, this is what it really looks like. Here is the extra embryonic visceral membrane, and then from here, this is the somatic mesoderm. Right here is your hypoblast, epiblast, amniotic cavity, and of course that will expand. See, it will expand outwards, and here is going to be our yolk sac, and that will be like ingressed. Here's our connecting stalk that will eventually form the umbilical cord, and here are the vascular lacuna and the endometrial blood vessels interacting. This entire thing is the syncytioblast, and see how the cytotrophoblast is thinning out into like only one layer, and then this would be the villi pushing into the syncytiotropoblast. So the yolk sac is the proliferation of the hypoplastic cells, and it occurs in 2 successive waves of the cell migration to form the yolk sac membrane, and it extends from the hypoblast into the blastocyst cavity. And the first wave begins on the 8th day, and it will form the primary yolk sac, also known as Hauser's membrane. And then the extra embryonic mesoderm forms and fills the cavity with some loosely arranged cells. By day 12, the primary sac will be displaced by hypoblast cells that form the secondary yolk sac, and the allantois will, of course, poke into it or penetrate it. There we go. And then the extra embryonic coelom or chorionic cavity will form when the extra embryonic mesoderm will split. And then the extra embryonic coelom separates the embryo from the outer wall of the blastocyst. So here are the maternal blood vessels starting to, interact with the lacuna, and then the syncytiotropoblast. And the placenta in this figure is starting to develop. Here is like a better picture. This is more in terms of like this timing, this period around like 8 to 12. Here are the maternal sinusoids, which would be like this, and the blood vessels. And this is the splanchnic layer. Here's the cytotrophoblast, and then syncytiotropoblast on the outside, and these are going to be the lacuna. Here's the connecting stalk, will eventually split into that. Here's the amniotic cavity. Okay, so by day 13, the embryonic disc is going to be suspended in the chorionic cavity by the connecting stalk, which will eventually form the umbilical cord. And then the definitive yolk sac will form after the extra embryonic mesoderm splits. And it's going to be made out of the hypoblast derived endoderm on the inside and the mesoderm on the outside. And the yolk sac is going to be the primary source of the blood islands, which are where blood cells develop. And they also um, are the progenitors of like the primordial germ cells. By week 4, the yolk sac has overgrown by the developing embryonic disc and then is kind of like ingressed and it disappears. But in rare cases, it persists in Merkel's diverticulum, which is like a little extra pocket that lies in the small intestine, and it can be harmless, but sometimes it can become infected, and then that's a surgical removal. It's kind of like the way the appendix is. Generally, it's harmless, but in an infection, during trauma, during something kind of traumatic, rupturing it, that's when it starts to act up, and then we have to treat it by surgery. So an extra embryonic somatic mesoderm will line the cytotrophoblast and the amnion, and then the extra embryonic splanchnic mesoderm will line the yolk sac. The chorion is made out of the extra embryonic somatic mesoderm and then the 2 layers of the trophoblast. And then the chorion will make the wall of the chorionic sac, of course. This plays a role in it's just like an extra layer of protection and to keep the placenta intact. So the maternal blood will go into the lacuna, and that's where the gas and nutrients will be exchanged with the between, like, you know, the endometrial veins and arteries and the villi, and the vacuoles of course will open in the syncytial trophoblast by day 9. That's where the blood will go in, or the maternal blood will go in. And then the maternal capillaries will expand into sinusoids, which are just, you know, larger vessels that are very tortuous, which means they like curl. And the sinusoids anastomose with the trophoblastic lacuna, so they make a connection. And by day 11 and 13, the cytotrophoblast will proliferate to make the extensions, or the villi, into the overlying syncytial trophoblast. And the growth is all induced by the extra embryonic mesoderm. The primary chorionic stem villi are extensions of the cytotrophoblast that grow out into the blood-filled lacuna, and they're all covered by the syncytial trophoblast. So nutrients and gas exchange and waste exchange really has to go through the 3 layers, right? So it has to go through the covering of the syncytial trophoblast, and then it has to go through the trophoblasts, and then it can be absorbed by the fetus, but it also has to go through, of course, the capillaries of the maternal side. Okay, so by day 16, the extra embryonic mesoderm will penetrate the core of the primary villi, and that will make it the secondary chorionic stem villi. By the 3rd week, the villus mesoderm will give rise to the blood vessels that will connect with the vessels forming in the embryo proper. So it kind of like just forms like these like kind of not very well defined vessels that will just kind of like do the job and exchange blood, nutrients, and gas, or I'm sorry, not blood, nutrients, gas, and waste. And then once they connect with the vessels forming in the embryo proper, that's when the vessels really start like taking shape and starting to dorsalize or ventralize. The tertiary chorionic stem villi will have the differentiated blood vessels, and the gas, nutrients, waste will diffuse over the 4 layers. I said 3, but I guess technically it is 4. The endometrium of the villus capillaries the loose connective tissue in the core of the villus, the cytotrophoblast, and then the syncytiotrophoblast. The decidua reactions is that the cells of the endometrium will undergo a change, and then they're filled with glycogen and lipids, and then the extra spaces are filled with extravasate, which will make the cells edematous, like swollen, and that kind of helps with osmosis and the diffusion of nutrients, gases, and waste. Hydatiform moles are like incomplete embryos, I want to say, but let's go through it more directly. So, a complete mole is made out of the conceptus, and it only consists of the placental membrane. It's missing the fetus. So, the female's body will go through all the steps like it is preparing for a child, but there's not going to be any child. The placenta villi of the complete moles are swollen and vesicular, and they form a lot of these structures that look like a bunch of grapes. And it is usually it causes an abortion in early pregnancy, and it can cause vaginal bleeding during the 6th to 16th week of pregnancy, and causes excessive nausea and vomiting. In the blood work, you will see there's going to be an elevated HCG level. The cells of a complete mole have the diploid karyotype, but all the chromosomes come from the father. There's not going to be any genetic information in the ovum. This can also be caused by a dispermic fertilization, but more commonly it's caused by a monospermic fertilization, but the sperm go through an extra duplication. So this can happen. There's going to be a loss of the maternal chromosome, so all of the genetic information comes from the father. Well, here's the dispermic, which means two of them. Two of those sperm are going to fertilize either an empty ovum, or one of the sperms will displace the maternal genetic information. This can happen when there's going to be diploid biparental chromosome. So this would be the it's going to be translocation, can happen and then cause this. Here's another dispermic. This would be also caused by a different kind of translocation added with a extra fertilization or extra duplication of either the sperm or the egg. The partial hydatiform mole is an abnormal fetus, and the swollen villi only are in patches. So this is the complete hydatiform mole, and it covers like all of the uterus, or it's the entire uterus is filled with it. Here, the partial, it's only in patches. Sometimes it can occur where there's going to be a mole and a fetus. This can lead to a normal fetus if the moles are kind of small, but if it's extensive and it keeps growing, it can press upon the fetus and strangulate the fetus by strangulating the umbilical cord, not allowing any nutrients to pass through. And here's the invasive moles. That's where it can start penetrating into the endometrium and the actual muscular walls of the uterus. The choriocarcinoma is when it starts to spread. And then the placental strike trophoblastic tumor is a trophoblastic tumor that is only in the placental kind of site near the ossus of the tubes. So the clinical symptoms are milder and slower to develop than the complete moles, and the spontaneous abortions generally happen later. The karyotype of the fetuses are triploid. So the gestational trophoblastic tumors are the carcinomas that will spread, and they're caused by the residual trophoblastic tissue remaining in the uterus after a spontaneous abortion or surgical removal of the hydatiform mole. So this doesn't really mean that it's caused by like a physical abortion. It just means that if the surgeon isn't careful, or they missed the spot where the hydatiform mole used to be, like if you don't remove the stalk, the mole remnant can grow and then it proliferates to form a tumor. Usually they are benign, but they can become malignant, and then it becomes the metastatic choriocarcinoma, and it's always caused by a hydatiform mole. The molar villi will grow into the myometrium, or the vessels, and the ligament of the uterus, and it metastasizes into the vagina or the vulva, which is the outer female genitalia. But more concerning, it can migrate to the lungs and the brain. This has a complete treatment or recovery if it's caught early and it's treated with surgery by either the removal of the uterus itself or removal of the mole along with chemo. Here you go. You can see all this. This is the healthy. Here's the implantation site. Chorionic layer. This is where they would invade. So there's a bunch of abnormal implantations as well. And normally the blastocyst implants along the anterior or the posterior wall of the uterus. And in a very worrisome and unfortunately common case, placenta previa is if the blastocyst implants too close to the internal os of the cervix, and then it causes a problem later in pregnancy because the placenta forms and bridges the opening, causing either severe bleeding in the second half of the pregnancy and during delivery. Because, okay, so normally the placenta is around here. Low implantation, it's very close to the cervix. Partial, it's already covering the cervix, and then a total placenta previa is going to just cover the lower half of the uterus. Another abnormal implantation is the ectopic or the extrauterine pregnancy, and that means it implants anywhere but the uterus, but generally implants in the follicular tubes. And in most ectopic pregnancies, the embryo dies within the second month of gestation, and it causes a severe amount of abdominal pain for the mother. So in this picture, right here is the ovary, and right here are the follicular tubes, and then right here is an ectopic pregnancy right here. It should have gone like down into the uterus, but right here, that's where it has implanted. And see how like narrow the tube is normally. So this is causing a lot of pain right here. Okay, so that's it for now. Thank you for your attention and good luck studying.